Bismillahirrahmanirrahim. This is the second lecture of the basal ganglia lesions. I will discuss the bilateral basal ganglia lesions. Alhamdulillah wa salatu wa salam ala rasulullah wa ala alihi wa sahbihi wa sallam ajma'in. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. آمين وأجمعين يا رب العالمين. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل. Ameen Ya Rabbal Alameen. Today I will discuss the bilateral basal ganglia lesions. They are more frequently bilateral in many pathologic conditions. The findings are not specific in most cases and must be considered in the context of the clinical status and other tests, but knowledge of the diseases that affect the basal ganglia can limit the spectrum of the differential diagnosis. Bilateral basal ganglia calcification are more common findings seen in approximately about 1% of all CT scan of the brain and has more than 24 causes. They are observed more bilateral basal ganglia lesions. They are more observed frequently in older people and are considered a normal incidental finding in elderly patients, especially the calcification and iron deposition. Bilateral basal ganglia lesion can be categorized into these categories, and I will discuss each category with example. The first category related to hypoxia, and we have hypoxic ischemic brain injury in term neonate or newborn, present as symmetrical involvement of the basal ganglia with or without thalami, with hyperintensity in the all sequences T1, T2, flare and diffusion, and associated with appearance of swelling of the affected structure. As we see here, the patient with hypoxic ischemic injury, acute asphyxia, we have hyperintensity noted and swelling in the basal ganglia and thalami with restricted diffusion. Another patient with hypoxic ischemic encephalopathy, as we see here, hypodense area involving the basal ganglia, caudate nuclei, and globus pallidus and thalami. Cardiac arrest in adult can cause also basal ganglia lesion, similar to brain injury, and also involve the cerebral cortex due to high metabolic activity of the gray matter in adults, and they appear as increased volume of the basal ganglia. The increased volume of the basal ganglia, it is not observed in adult as in neonate. MRI has a prognostic value, extensive lesion, cortical and with restricted diffusion particularly indicate poor prognosis. As we see here, patient with cardiac arrest after 3 weeks, and we see hyperintensity of the basal ganglia in the basal ganglia with diffusion weighted images. Carbon monoxide poisoning leads to similar effect of the ischemia, hypoxic ischemic changes due to inability of carboxyhemoglobin to supply oxygen to the brain, and globus globi pallidi are the most common area of involved, as well as with periventricular and centrum semi-ovale white matter. As we see here in this patient with toxic poisoning of carbon, we have CO poisoning. As we see here, we have involving the medial aspect of the basal lentiform nucleus, globi pallidi bilaterally, involving the globi pallidi, and also involving the centrum semi-ovale, and this is the delayed changes. The other category related to acquired metabolic disorder, we have the hypoglycemia can affect the basal ganglia and appear the basal ganglia as on the T2 and diffusion weighted images as hyperintense. Here, patient with hypoglycemia, and we have the caudate nuclei and the lentiform nucleus has hyperintense intense to the gray matter, or isointense to the gray matter with diffusion restriction, with restricted diffusion in this patient with hypoglycemia. Hyperbilirubinemia, it is lead to also involvement of the basal ganglia and appear as hyperintensity in the globi pallidi. As seen in this patient, we have the globi pallidi involving the bilaterally in this patient with hyperbilirubinemia. Other categories related to inherited myelin disorder, and we have Canavan disease, and it is autosomal recessive, and disease, and it is involved white matter with injury to the peripheral white matter and U fibers are and the sparing of the centrum semi-ovale. And a spectroscope in has high peak metabolites. And this patient with Canavan disease involving the globi pallidi bilaterally and involving also the caudate nuclei and sparing the caudate, it is involving the globi pallidi bilaterally and sparing the caudate nuclei. Krabbe's disease, also another one of the causes of the basal ganglia hyperintensity on the CT scan in the early stage of the disease. Related other category, it is related to inherited metabolic disorder, as in Leigh disease, and it is inborn error metabolism transmitted as autosomal recessive trait affecting infants and children. And in this patient, we have the Leigh disease. We have asymmetric involvement of the lentiform nuclei bilaterally associated in this flare images and with restricted diffusion on this image, the right side involving more than the left side. Wilson disease or hepatolenticular degeneration, it is inherited as autosomal recessive trait and result in deposition of copper in the brain and the liver. Also, the lentiform nuclei are typically involved and indicate the disease. And here, this patient with Wilson disease, we have hyperintensity of the globi pallidi, bilaterally involving this axial proton density weighted image. And this patient with Wilson disease with affection with more involvement of the putamen, but also can other part of the basal ganglia can be involved, as in this patient with caudate nuclei and part of the thalami involved. If the thalami it is involved, the ventrolateral aspect it is involved only. Other category, it is related to degenerative disorder, and we have infantile bilateral striated necrosis, and it is bilateral spongy degeneration of the caudate nuclei and putamen, which form the striatum. And in this patient, we have patient with infantile bilateral striatal necrosis involving the both putamina in the early stage of the disease in this T2 weighted axial image. Huntington chorea disease, it is autosomal dominant disorder with chorea in the clinical picture, can mimic infantile bilateral striatal necrosis on the MRI, and we have this patient with Huntington's disease, hyperintensity involving the caudate nuclei and also involving the putamen, as we see here, and we see here, and the caudate in nuclei. This disease, Panthotenate kinase-associated neurodegeneration, PKAN, and it is autosomal recessive. We have demyelination of the globi pallidi, will result in high signal intensity in the T2 and giving the appearance of eye of the tiger. And we have this patient with panthotenate kinase associated in neurodegeneration, and we see the eye of the tiger sign seen in the T2 coronal images. We have the FAR disease, extensive. In this disease, we have extensive calcification, and it is seen on the gradient echo weighted images or susceptibility weighted image. And the calcification paradoxically sometimes seen hyper intense on T1 weighted image. And we see here the T1 hyperintensity on the basal ganglia with the gradient echo seen on the with the susceptibility weighted images. It is a blooming effect, and this is a calcification with Favre's disease involving the globi bellidae. Un, un, unidentified in neurofibromatosis object, and it is previously it is called unidentified bright object, and it is typical of neurofibromatosis type 1. Basal ganglia are most common, most often involved, and with localization in the lesion, and shows hyper intense signal on T2 and flare images, and iso-intense in T1. Lesions are in the globi bellidae, as we see here in this patient with hyper neurofibromatosis type 1. We have hamartomas in the high signal intensity on T2 and the flare images located in the global bellidae, as we see here in this patient, and on T2 and T1 are hyper intense. Multiple system atrophy, we have it is adult onset, sporadic, progressive in neurodegenerative disease, and it is characterized by Parkinsonism, ataxia, autonomic failure, urogenital dysfunction, and corticospinal disorder. And we have the hyperintensity in the posterolateral margin of the putamen, and putamen signal hyperintensity relative to the globus pallidus on the T2. As we see here in this patient with multiple system atrophy, we have slit-like hyperintensity involving the posterolateral aspect of the putamen here and there, and this hyperintensity relative to globus pallidus on T2. Infectious causes, we have the herpes simplex virus infection, and we have also the bacterial infection, and this patient with herpes encephalitis, as we see here, typical involvement of the temporal lobe in this patient, and involving of the also symmetrical caudate and lentiform involvement in this patient with restricted diffusion and some enhancement. Here, patient with infection due to bacteria and involving the basal ganglia with diffusion restricted imaging. C. Jacob disease. It is rare, progressive neurodegenerative disorder caused by deposition of the pathological isoform of the prion protein in the central nervous system. And we have this patient, 65 years old with C. Jacob disease, and the lesions are involving the basal ganglia, accompanying with cortical involvement, but not shown in this patient with restricted diffusion in the basal ganglia and caudate nuclei. Here, another patient with involving of the thalami and involving of the thalami with restricted diffusion, giving the appearance of the Bolvinar sign. And this is a classic sign of the CJ disease. Iatrogenic causes, we have the some materials like magnesium and in the parenteral feeding, long-term parenteral feeding nutrition can deposit the manganese, and this involves the globi pallidi and appear as T1 hyperintensity. And also another cause, central pontine myelinolysis, and it is demyelinating disease result in from the rapid correction of hyponatremia or other disease entities like cancer, diabetes, renal insufficiency, and alcoholism. And in this patient, we have extrapontine myelinolysis involving in this patient involving the caudate nuclei and involving the lentiform nuclei. Here, another patient with osmotic myelinolysis involving the basal ganglia, as we see here, and involving the the cerebellum and involving the bones. Radiation, one of the causes with intrathecal chemotherapy, and in this patient has radiotherapy and for lymphoblastic leukemia with CNS involving of the lentiform nuclei manifested by calcification on this axial CT scan. Other causes, we have involved the basal ganglia by methanol and cyanide poisoning, and in this patient we have the methanol poisoning demonstrate diffuse white matter anemia and involving the basal ganglia. HIV also can cause involving the basal ganglia, and other causes, also drugs, also can involve the basal ganglia. And thank you for listening, and hoping to see you soon in another talk. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.